So when we start in a laboratory and we finally made it from all those jobs that you just can't wait to get away from, like sorting specimens and making agar, and they finally say to you, guess what? It's time to start learning a bench. Many of us start on the urine bench. Lisa, is that the bench that you started on?
And then we culture them with a tiny little loop. It's got a 1 microliter loop, and we put it on an agar plate.
Oh, I think we might have one of the agar plates here.
Oh, yeah, we do.
So here is, I'll just find you. You can see one side. Do you want to describe it?
This is a horse blood agar McConkey split. So this is horse blood agar here and McConkey agar here. And on this side of the plate, our organism, which is the most common cause of urinary tract infection, E. coli, that actually goes this beautiful pink colour, and that's called lactose fermentation. And like I said, that's the most commonest cause of a urinary tract infection. With our urines as well, we do a cell count to see if there is an infection, and usually more than 100 cells is a significant count. We count white cells, red cells, epithelial cells.
And how many urines would you process in one night at your laboratory?
We process just over 2,000 urines a day.
Wow, 2,000!
How many people are doing that?
There are about 6 or 7 lab assistants and 2 or 3 scientists.
Okay.
So that's the setup plate.
Yeah.
The reading, that's the setup. The reading of plates during the day is about 4 or 5 people reading.
Yeah.
So they're supposed to read about 400 urines, which is a lot. It is
Yeah.
a lot.
Yeah. The microscopy?
The microscopy is a lot of it's automated, but we do still do quite a lot by manually with the microscope.
And do you ever get sick of looking at white blood cells down the microscope?
No, not really. Well, I mean, if you have to look at a lot, it can be a bit, but it's okay because like every urine is a different patient. You got to remember there is a patient at the end of every specimen, and every urine is
It's
sort of
funny because whenever I'm doing lots and lots of repetitive activity, like lots of urine microscopy, I'm focusing on the cells.
Yeah.
And the cells, I don't know, they've got a life of their own.
Yeah.
And I think that's when you know you're a real microbiologist because you look at agar plates and you're fascinated by what's there.
Yeah.
You look down the microscope and you see cells as individuals. They've all got, I don't know, did you get that?
I think you're a real microbiologist when you go on holidays and you can't wait to come back and smell the lab.
Wow, that is super.
The smell of the organisms growing, it's like, coming home.
Yeah. And look, I remember for the first 3 weeks that I worked in the lab, I didn't feel very well because I was processing the sputum samples, and that was like so shocking to me that we would be working with urine, feces, sputum. But after 3 weeks, it just became chemicals, and I didn't really identify them as those things. They just, because you saw so many of them, you were desensitized to their smell, and even these days you do all the poo in the fume cabinets, you can't smell it anyway. So it's not bad. And while we were talking about the urine bench, we mentioned the horse blood McConkey split, which is what I used to use, but nowadays we're using something, look at this. Isn't that beautiful?
For example, this is a Klebsiella.
Wow, what a difference.
Completely different.
So they would have looked identical on that horse blood before.
Yes.
Here's a staph, sort of like a light pink. And this is a particular staph that likes to cause urine infections. And here we have Proteus. I'll just put it up there, a brown colour. Amazing. So these chromogenic agars are such an advance on. Yeah. So here we have staph. There's a mixture on here, staph and E. coli growing on this plate. So one of the things that we wanted to mention to you is that you're also a microbiologist when you're very careful about which colony you touch, because it's really important that we set up susceptibility testing. So can you see here we've got paper discs with different antibiotics, and we can see that the organism is not growing near the antibiotics, so it's susceptible. We'll show you another one later where it makes such a difference, the reporting of susceptibility. Helen, you've done some blood cultures and CSF. Do you want to tell the students about probably the most important samples in the lab?
Well, CSFs, we had a lot of CSFs when we were at the children's because in those days, like 30 years ago, we didn't have the vaccine against the HIV, Haemophilus influenza type B. So babies and young children were particularly susceptible in that period from 2 months to 2 years. So after they lost their mother's immunity to when they started to gain their own immunity, we had very many Haemophilus influenza type B CSFs. So with the CSF, we would do a protein. So protein would usually be high. We would do a white cell count, and we stained the cells with just a blue dye that took up the stain, and you could tell if it was lymphocytes or polymorphs. And by looking at the ratio, normally if you've got a bacterial infection, you'll have like 90% polymorphs. But if it was a viral CSF, like if it was a viral infection, then you'd have mainly lymphocytes. And we also did a glucose, and the glucose should have been like, sort of 1 to 5, and it would usually go really low if it was a positive CSF.
Okay.
And they were important to get a result quickly so that they could start treatment straight away, because that could be a life-threatening disease.
And I noticed you put out a couple of plates for us to show us how important that susceptibility testing is. Do you want to show them your strep from a meningitis here?
So we've got a strep pneumo, and this one is fully sensitive. You can see that there's a zone around those discs, and this one here, one of the discs has got hardly any zone at all. And that's because it's resistant to that particular organism. So it's important to have that information to give to the doctor so that they can treat the patient with the correct antibiotic to effect a cure.
Yeah, fantastic. So that's where our job is so critical, because we make diagnoses that can actually influence patients' treatment, and I think that's really the fuel that keeps us going through our careers, isn't it? That we're making a difference to patient lives.